implies there is a correct way to ventilate patients with COVID-19 patients. But all I want to do this afternoon is just share with you a model, or at least a ventilation that is based on a conceptual model that reflects the phases of this disease. So first of all, just the first slide, you can see that United Kingdom is rapidly catching up with the rest of Europe in terms of numbers, confirmed cases. And here, GSTT, Agassiz St. Thomas's, you can see the curve of patients who are ventilated with COVID is rapidly increasing, reflecting the kinetic of the pandemic in Europe and in UK. Now, this is not, I'm not going to spend much time on this. This is very preliminary data just for you to see, but actually you can see the number of patients, the driving pressure, and the ventilated days, and mainly have a moderate severe PF ratio that is compatible with a moderate severe disease. But I think it's important to look back and think about how these patients present from an hypoxemic perspective. So the hypoxemia in these patients is mainly threefold. It's due to a dysregulation of pulmonary perfusion, which is very important. And I think the role of the pulmonary microthrombosis is becoming more and more relevant, and perhaps we'll learn more in the future about the pathological and also therapeutic importance of the microthrombosis. And finally, on the other side of the spectrum, there is the frank pulmonary edema, which here I define as ARDS-like, and hopefully will make sense in a second where the reason why I'm saying ARDS-like. So if you compare these two chest x-rays of patients with similar PF ratio, but very clearly have got different pathology, and still they're both COVID-19 positive. And equally, you can see the CT scan, and the patterns varies from your left to the right, from a ground glass, very limited consolidation, to on your right-hand side, quite frank consolidation, which resembles more ARDS. So if we think about it, and the way we conceptualize the hypoxemia is the dysregulation of pulmonary perfusion first, which when associated with the mechanical characteristics of these patients and the radiological appearance, there is a pattern there that links the hypoxemia with a low elastance, so high compliance, a low VQ matching, a low recruitability, and therefore a limited response to PEEP. And the microthrombosis is there, which obviously create not only difficulty in lung perfusion and hypoxemia, but also some dead space, and therefore increase in carbon dioxide. And on the other side, there is the collapse or the edema, the ARDS-like, which has a high lung elastance, higher recruitability compared to the other type, and a shunt that is more substantial, and they respond to higher PEEP and prone positioning. So this is with Professor Gattinoni and other co-workers, has been named as phenotype L, and L stands for low everything, low elastance, VQ, recruitability, and limited PEEP response. And in contrast, the other one is a phenotype H. So I think it's very important when we conceptualize and we see these patients at the bedside to start an early categorization into these two phenotypes, because the treatment, or at least the management, is quite different. But also it's important, you can see the arrow that I put there, that some of the phenotype L obviously will progress into a phenotype H, depending either on disease progression, but also the way we manage the early management of phenotype L. And this is, you can see this picture again taken from an editorial that will be in press very soon. And you can see that despite the same PF ratio, the CT scan appearance is completely different, and the distribution of normal lung and consolidated lung is quite different between the two categories. And I think the important one is actually the effect of the SARS-CoV-2 virus on the ACE2 receptor and some of the differential effects on the angiotensin receptor 1 and 2. And you can see the one as at the beginning, there is a profound vasodilatory effect where the shunt and the abolition of hypoxic vasoconstriction prevails, but then later on there is inflammation, there is vasoconstriction, and there is fibrosis. So when you compare it with the classical definition of ARDS, you can see that the COVID-19 actually doesn't fit strictly all the criteria of the Berlin definition. It doesn't fit the timing very well. Some of these patients present quite late. It doesn't fit the chest imaging, at least for the phenotype L, which is the majority of the COVID-19 at presentation, and you can see the oxygenation criteria remain relevant. So the first point is COVID-19 pneumonitis might not be similar or equal to ARDS. And so based on that initial two phenotypes, we are treating these patients with respiratory failure, mainly hypoxemia from COVID-19, very differently depending on the two phenotypes. So there is a first stage where we want to assess shunt fraction and the severity of the hypoxemia. There is a second stage when we look at the risk of patient self-induced lung injury and therefore the progression from L into H phenotype. And then we screen for strain, so the likelihood of an injurious ventilation in terms of tidal volume. And then in terms of PEEP and recruitment and prompt positioning, an early identification of the phenotypes. And finally, the failure and escalation strategy when we look for extracorporeal support. So I'm going to go briefly all these stages so we can clarify this process, and then maybe we can discuss different phases later on in the discussion phase. So the first thing is the non-invasive. We do that with a 15 liters oxygen. We use a particular target, so 90 to 94, and we may use this might be in A&E or might be on the ward, and then we assess very early the work of breathing. Now, if the work of breathing is high, then it's very clear that this patient needs to be treated more aggressively because they might have a more fulminant disease, more hyperacute disease. I'll speak about this later on. Or if the work of breathing is low, a time-limited use of, for example, non-invasive CPAP or staying on oxygen can be more prolonged. But I would say this has to be time-limited and with strict monitoring of work of breathing. And the reason for the oxygen challenging is very simple, and it's essentially the well-known concept of estimation of shunt fraction. Essentially, if the SpO2 or the saturation does not increase to a certain level, let's say above 95%, in all likelihood, the shunt fraction is elevated and more in the range of 30 to 40% or higher. So these patients have got a moderate or a severe hypoxemia, which may not be easily reversible just with oxygen. I think the other thing to consider is the work of breathing, and it's to do with the respiratory drive. Now, the respiratory drive can have various sources. So clearly the hypoxemia drive the increase in tidal volume, therefore increases the swings in esophageal and pleural pressure, which has an effect on stress and strain of the lung. The other important point on the other side is the pulmonary edema. That leads to an elastic work of breathing and an increase in respiratory rate. So in a way, when the respiratory rate increases, already there is the stage of increase in tidal volume is past, and therefore the disease is more severe. There is also the metabolic drive. Some of these patients are incredibly inflammatory and febrile, and the oxygen consumption and demand is increased, and that leads to respiratory drive. But I think what is coming more clear in the literature now is the neurotropism of the SARS-CoV-2, particularly around the midbrain on the respiratory and cardiovascular control. So some of these patients might have a quite significant work of breathing, but they don't perceive it. So the subjective dyspnea might be less pronounced compared to the work of breathing. So I think, what can we do? Obviously, the FiO2 is an important first measure. And the other thing is things that we can improve VQ matching. So maybe prone position in these patients might work very well. On the other side, for the elastic work of breathing, we need certainly mechanical support and sometimes pharmacological support to control the respiratory rate and therefore the stress and strain of the lung. But I think the neurotropism is important and has to do with delirium, cognition, the frequently reported anosmia that some of these patients present with, and clearly the cardiorespiratory compromise, which some patients have to the extreme of having an unexplained cardiac arrest. So the question is what to do next. And clearly there are a series of options. Some of them are to do with medical choice, and others sometimes organizational. And I think there are considerations. One, certainly the infection control is a big issue. In some hospitals, the use of high flow is not allowed because of the infection control issues. The other consideration is about the support that the patient actually requires, both in terms of respiratory work of breathing, but also how likely is this patient to fail, the degree of hypoxemia, the tolerance to the interface, for example, and the control of the transpulmonary pressure. The other consideration, which is quite important, this is not a disease that is easily reversible in 1 day or 2 days, like, for example, might be a cardiogenic pulmonary edema. So it might be less responsive to a short duration of positive pressure ventilation. But I'll tell you all about it, or a little bit more, later on in the course of the talk. And the fourth consideration is clearly resources. Resources in terms of ICU beds, in terms of staffing, availability of ventilators, and clearly oxygen. Some of these high-flow oxygen or CPAP, they use an enormous quantity of oxygen and gas, and therefore that needs to be taken into consideration. So I'm just going to say something about oxygenation, and clearly the oxygenation, we all know CPAP or non-invasive ventilation improve oxygenation, the PF ratio improves, but some of it has to do with the edema itself and some of the effects on the alveolar level, but some other things has to do with more of a hemodynamic impact. I mean, you will remember this paper in 1979, which just basically shows how the use of CPAP may be associated with a depression in cardiac output. And as the cardiac output goes down, you can see with a different PEEP, then the shunt fraction goes down. And therefore, there is an apparent increase in PF ratio, which is exclusively related to a change in shunt fraction. The other thing to consider is the failure rate. We can see this is from the LungSafe data for the non-invasive ventilation in ARDS patients. And you can see that the survival probability of patients with moderate to severe respiratory failure is certainly lower in patients who received a non-invasive ventilation. And on the right-hand side, you can see the mortality in blue, and the mortality if NIVs failed in yellow. And clearly the failure rate is quite elevated in hypoxemic respiratory failure. And this is all data from Massimo Antonelli, and you can see the intubation rate can be quite substantial. And even when compared to conventional oxygen therapy, NIV is associated with greater intubation rate and lower survival. And NIV is a factor, an independent factor related to ICU mortality and 90-day mortality. But what is more important, I think, in this particular disease, the COVID-19, is that some of these patients might be led to have sort of the use of non-invasive support might lead to a delayed intubation. You can see this is a study now in 2002 that shows in hypoxemic respiratory failure, patients with de novo respiratory failure, in other words, they didn't have any previous cardiac or respiratory support, and then they die, they do not survive, the intubation, there is a delay of a few hours in the intubation of these patients. The other thing is about worker breathing. Clearly, CPAP or non-invasive ventilation can support worker breathing, but you can see that the worker breathing needs to be monitored. Clearly, the gold standard would be the use of esophageal pressure. You can see a movie there and a waveform, and you can see that if the worker breathing is excessive, that will dictate immediate intubation of this patient. But also very interesting to see this data from Laurent Brochard group. You can see that the CPAP alone might not be very efficient or effective at reducing elastic worker breathing, despite the fact they might improve the PF ratio. And one of the things that we need to keep in mind, although sometimes with some CPAP machines might be difficult to measure, is the expired tidal volume. So here you can see two studies that show at the same time consistently that a tidal volume greater than 9.5 or 9 mils per kilo of body weight is associated with increased NIV failure and increased mortality. So I think this can lead to a vicious circle where the impaired gas exchange and the low lung elastance leads to an increase in respiratory drive, which increases the esophageal swings and increase the transpulmonary pressure. That leads to capillary leak and in a very inflamed lung edema, which perpetuates the lung injury. And here, this is a perspective where the authors, Laurent Brochard, Slatsky, and Pesenti, clearly say that sometimes a lung protective ventilation can be applied almost prophylactically as a supportive therapy to minimize progression of disease. And this brings me to the next point, which is the course of the disease. I mean, you all have seen by now that I think in my mind there are three patterns. There is a pattern where the severity is very high, the disease is hyperacute, the hypoxemia is severe, the breathlessness is severe, and that leads to immediate intubation. However, there is a more indolent or even improving course where there is moderate or severe hypoxemia, but only moderate worker breathing. And patients might be ventilated invasively or often non-invasively for a number of days until there is the biphasic response where after an initial indolent course, there is a biphasic with an increase in severity, which can be very acute after 5 to 7 days. And the deterioration may be associated with hyperinflammation. So these patients are, CRP goes up, the ferritin goes up, the lymphocyte count goes up, they are febrile, and they need multiple organ support. And so that's why we go into the intubation phase where we look at strain. So the first thing we do, we ventilate them in volume control. In that way, we can measure the driving pressure. And we don't use super low tidal volumes. Some of these patients, who have said about 60% of these patients have completely normal compliance, and we don't want to underventilate and cause hypoventilation atelectasis in these patients. So we check the driving pressure. If the driving pressure is less than 15, we keep them 8 mils per kilo. And if it's greater than 15, clearly the gas volume or the lung volume is small, and therefore we reduce the tidal volume to match that strain. And we continue to titrate the PEEP if required to meet some targets. But we don't go higher than 15 of peak pressure, because clearly we don't know at this stage the phenotype, and we want to characterize the phenotype before we can optimize the ventilation. So once we increase the PEEP up to a certain level, then we look at the compliance. If the compliance is low, so less than 14 or than 40 or greater than 40. And this is because of these two pictures. So on the left, you can see a patient with a full lung, completely normal, and the other one you can see with a small lung volume. Clearly, these two patients, regardless of the level of hypoxemia, where they might be similar, they need to be treated differently. And what we do is, if the compliance is near normal, then the first thing we do is prone position, because so clearly we want to optimize the VQ matching, and perhaps a trial of a pulmonary vascular reactivity test with some pulmonary vasodilators. However, if the compliance is less than 40 or is compromised, in that case we know the FRC is reduced, the lung volume is smaller and might respond to PEEP or to short recruitment maneuvers. And sometimes we use airway pressure release ventilation to improve recruitment and maintain alveolar stability. This is just a little video just to show the effect of the inspiratory time on alveolar stability. And this is one of the modalities that we use occasionally to increase the mean airway pressure, but at the same time maintain a lower peak or plateau pressure. Clearly, there is the phase where, after trying prone position or a PRV for at least 6 hours, or clearly sooner if life-threatening, we need to make a decision if everything fails. And clearly, some patients, you can see some chest X-ray below where there might be a rapid fulminant progression of the disease to an hyperinflammatory state that might need extracorporeal support, and oxygenation cannot be maintained just with conventional treatment. And I think when we think about ECMO, well, in any condition, but certainly in a situation where the resources might be more difficult to manage, in a situation of pandemics, clearly we need to think of 4 questions. The first question is clearly, is the pathology reversible? Not the pathology necessarily that led to the respiratory failure in the first instance, but the pathology that we are dealing with now. So the hyperinflammation, the multiple organ failure. And the second thing is to think about the patient. So is the patient able to recover? And they seem to be related questions, but they're actually very different. And if the patient is able to recover, has to do more with frailty, comorbidities, and the ability to sustain a prolonged course of ECMO and therefore rehabilitation, particularly in a situation where resources in terms of rehabilitation, physiotherapy, etc., might be limited. The third and the fourth has to do with gas exchange and mechanical ventilation. So the third is the gas exchange so severe that it's life-threatening and we need to do something now? Or is the mechanical ventilation injurious? So the first two is about patient selection, and the second two is about timing and indication. Now, I think it might be in different countries. Certainly in the UK, there are ways of looking at these questions, and also candidacy for ECMO. And clearly the frailty scores might be one of the things that we need to look at, and some of the other scoring systems that, although we don't use normally, we might need to use it now in situations when resources in general and ECMO resources might be more limited. And I want to conclude just with a picture of 4 recent cases that we had of COVID-19 who needed ECMO. And you can see the faces. You can see on your top left is 34-year-old postpartum, which she followed an hyperacute course. So she became very unwell very quickly, could not be oxygenated, could not be ventilated, and she was incredibly inflamed. The second one on the other three actually presented as a biphasic or delayed response. They are either 50, 46, or 32-year-old. Biphasic in a way that received non-invasive ventilation first for 2-3 days, then intubated, some of them quite promptly, but without any adverse events, but then remained ventilated for several days, sometimes 5 days. And you can see the progressive deterioration in this lung injury to the point that most of the lung is now consolidated, the one on your left-hand side, and you can see the top right actually having severe barotrauma. And the bottom right is a more recent one, patient we admitted to the unit about 2 days ago, who a 32-year-old male with a very severe hyperinflammatory phenotype with hyperpyrexia, temperature of 41, large doses of noradrenaline, and ferritin was greater than 10,000, hypertriglyceridemia, essentially the phenotype of an hyperinflammatory syndrome. And I would like with that to give you a summary, which in my view are things I've learned over the last few weeks. And clearly we come quite late compared to other countries, such as Italy, for example. But anyway, these are my 3 points that I'd like to share. The first one is that early recognition of the hyperacute disease is important. Clearly a need for immediate intubation, and these patients are high risk of cardiovascular events. Some of them are related to the myocarditis process, but some of them might be centrally mediated, essentially with the effect of the virus into the midbrain and the cardiorespiratory control. The second point is that a short and judicious use of CPAP might be useful for hemodynamically stable patients with moderate hypoxemia, not severe hypoxemia, particularly the ones who've got low respiratory drive and low inflammatory phenotype. But I think we need to be aware of the biphasic course of the disease, and some of these patients might fail quite late. And I think it's important to know about that to see where we can look after optimally this patient. And the third one is an early differentiation of the L phenotype. So this is the phenotype with preserved compliance with dysregulated pulmonary perfusion, because in these patients, we need to balance the use of PEEP with the perfusion. And sometimes the use of IPEEP or PEEP FiO2 scales, as they've been published in the ARDS, sometimes some of the guidelines might not be beneficial, and in fact they can be detrimental. And just I would like to say that this phenotype is not ARDS. And with that, I would like to thank you for your attention. I just stop here my presentation.